So covering the topic is unique features of hepatitis A vaccine. My contents will be structure and genome, replication cycle, diagnosis, natural history, clinical presentation, atypical variants, and management. So I'll not go into details of all this, but this is just a prelude, is that it's a non-enveloped virus, a hepatotropic picoRNA virus. It has 6 genotypes, and the important thing is genotype 4 to 6 cannot infect the human beings. So we are only worried about genotypes 1 to 3. This is the replication cycle, a very busy diagram, not much of clinical significance. Only thing what we need to understand is that the virus, this receptor, if you see this receptor, HAV-CR receptor, this is common for hepatitis A and E. So both hepatitis A and E can enter through this receptor, and that is why the co-infection is common. And chances that if you have hepatitis A, the hepatitis E can also go along with the receptor. And so same comes through fecal-oral transmission. So this is what I just wanted to bring. Okay, now coming to diagnosis. Hepatitis A specific IgM antibodies are typically found in an earlier stages of disease and can last for 6 months. The IgG, we all understand, can last for many years and is a marker for previous indication or a vaccination which has occurred. Then there are certain fallacies in IgM, because when we get an IgM anti-HAV report positive, we say that it is acute viral hepatitis, hepatitis A. We do not think about something else, but we need to think about something else, like in a scenario of autoimmune hepatitis, there can be cross-reactivity. So a child who is suffering or a patient who is suffering from an autoimmune hepatitis, uska antibodies may give a false positive IgM anti-HAV. Then another entity which is now also being recognized is the transfusion-associated hepatitis A. And though the risk of transmission is quite less, considering that the life cycle of hepatitis A is small and the whole process of, but still it is recognized entity, and it may be later on screening also in the blood banks may be done. If you see the clinical outcomes of hepatitis A, it is asymptomatic without jaundice, usually in children less than 5 years. Symptomatic with jaundice with self-limited, usually this is the most, if you see a manifestation around 95 to 98%, which we see. Cholestatic is around 5%, then relapsing, and then finally fulminant hepatic failure around less than 1%. So clinical symptoms is primary is asymptomatic, as already discussed. However, what we need to understand is the virus specific antibodies are usually detected 3 to 4 weeks after infection, and with the occurrence of the antibodies, the fecal release and viral replication goes down. So it is a sign of recovery. This is important in terms of the socio-demographic profile. Okay, this has already been done. This is the natural history of a classical viral hepatitis which happens. We need to understand this graph. Moynak has beautifully drawn it in his article which was published. And it clearly shows that whenever we see a case of viral hepatitis, there is importance of prodrome we need to understand, that it always starts with fever, loss of appetite, and vomiting and nausea, followed by occurrence of jaundice. So anything which precedes the jaundice is a prodrome, and this is a mark of viral hepatitis, whereas in cases of other causes of fever with jaundice, like enteric fever, leptospira, dengue, in all of them, the fever and jaundice are coexisting. So very important history when we take any history of viral hepatitis. These are extrahepatic manifestations. I'll not go into detail. However, what we need to highlight is the atypical variants. So atypical variants is any deviation from the classical presentation, and most common atypical presentation is the cholestasis, which is around 15 to 17%, and with hepatitis and ascites and intravascular hemolysis. So I'll be discussing in a few slides what we mean by prolonged cholestasis. So if you see this graph, there is prodrome. Initially, the bilirubin is minimal. The bilirubin starts to rise, but what happens in prolonged cholestasis, the bilirubin tends to remain very high. Earlier, what we had seen is that the jaundice was going down, but at 3 to 6 weeks, the bilirubin tends to remain high, more than 10. The enzymes come back to normal, say around 500 million, which was earlier 1000 in 2000s. And once you have these features, you have clinical presentation of pruritus, which is in which you add UDC and rifampicin, which was discussed in HEV also. And finally, there is clinical improvement and the LFT normalizes by 12 to 16 weeks. So if you see out of all the cases of prolonged cholestasis, hepatitis A is the most notorious one, which is associated with. The usual period from jaundice to develop itching or cholestasis is around 15 to 30 days. We always need to take history of other causes of intrahepatic and extrahepatic as differential to cholestasis in hepatitis A virus. However, whatever important history is that we should take also a history of drug-induced cholestasis. Drugs which can cause cholestasis, they can mimic some sort of cholestasis-associated viral hepatitis. Patients are being prescribed drugs even for viral hepatitis, which are undue, which is not required. Specifically, I would like to say about the herbal medications. Many of the herbal medications which are given for liver disease tend to induce cholestasis, and that is one of the important features. So UDCA helps in majority. Rifampicin is added in around 20% of cases. As discussed earlier also in one of the questions, steroids may be used, and this is only case series or case which is where we can give prednisolone at 1 mg per kg per day for 2 weeks. These are only case reports where cholestasis. Coming to the next scenario is of relapsing hepatitis. If you see relapsing hepatitis, it is basically there are 2 episodes of jaundice with interval of around 4 to 8 weeks between 2 episodes. These episodes are differential, and it can be monophasic relapse or it can be polyphasic. You can have even 2 to 3 episodes of these occurring together. Duration is from 2 months to 10 months, can long last, and LFT abnormalities can persist up to 1 year. So the second or subsequent phases may be icteric or non-icteric. The peaks of liver enzymes may be variable. It can be similar to what the first was, or it can be even higher or lesser. They may have the same severity, less severity, or even go up to liver failure. So the relapse doesn't signify it will be a severe disease or it will be a lesser disease. It can happen anything. So HAV, RNAV can be detected, and IgM anti-HAV remains to be present. Differential diagnosis includes AIH, sclerosing cholangitis, Dubin-Johnson's-Gilbert, and very important for pediatric perspective is the hemolytic anemias, which are there. So treatment is supportive with close monitoring. Then the another scenario which comes is acute viral hepatitis with ascites. This is something which we need. This is something which is not usually seen in adult population, but very frequently seen in pediatric population in our context, where we have children coming with ascites. Normally, it was said that ascites means chronic liver disease in adult scenario, but in our pediatric population, it is viral hepatitis. If there is ascites, there can be ascites. And usually what we see is occurs around 2 to 8 weeks, and there is high SAG ascites, and there is no stigmata of chronic liver disease. So it's present in around 13% of cases, which 38% are clinically detectable with high SAG. 11% may have infection. Pedal edema is around 30%. Pleural effusion is around 40%. Risk factors are younger age, lower serum albumin, high prothrombin time. If the child is having all these findings, he may have these ascites which is occurring. Diuretics is required around half of the cases, and they respond well. As the ascites, the resolution of ascites is co-occurrence with the resolution of the liver disease. Just soon as the liver is getting normalized, the ascites is also going down and tends not to reoccur. And finally is late onset hepatic failure. It is the definition wise, if you look at jaundice and encephalopathy should be more than 4 weeks. Ascites is 94% of cases and 50% of HE. Presence of coagulopathy. Ascites can be there normally in also acute viral hepatitis as we discussed, but if the ascites is associated with coagulopathy, means it is late onset hepatic failure. Whereas if it is only ascites with a normal prothrombin time, it is ascites with acute viral hepatitis. So you need to think about coagulopathy as the differentiating. So presence of coagulopathy differentiate late onset hepatic failure from ascitic form of acute viral hepatitis. Again, notorious is hepatitis A. In adults, this scenario occurs in hepatitis B vaccine. Mortality is higher and listing for transplant should be considered. This is one of the scores which is given by the ILBS group, where they said that if the INR is more than 3.1, jaundice to encephalopathy is more than 10 days, and HE grade 3 and 4, this should be listed for transplant. So if you have 2 out of the 3 criteria, this was specifically for hepatitis A, they said that please list in the patients for transplant. So coming to the management, final slide about acute viral hepatitis, hepatitis A. These are the questions which you usually ask. I'm being a pediatric gastroenterologist, so mainly the questions come on from the parents is about what is the dietary advice, when to admit the patient with acute viral, IV fluids, any specific medicines, what's the role of vitamin supplements, what are liver tonics, when do we need to get an LFT repeat done, and when to return to school. This is a very common question which comes from the parents. So normal diet, no restrictions. The fiction of using glucose, juices, protein restriction, fat restriction should not be there. Prescribe a very normal diet. Even in fact, it has been seen that if you reduce the diet, it leads to later on, leads to longer recovery time. Admit if there's features of hepatic encephalopathy, PT is prolonged, the liver size is decreasing. Occasional indications could be persistent vomiting and severe anorexia. Only symptomatic medications are required. No specific medicine is there for hepatitis A. There is no role of any of the drugs as such to be used in a routine case of acute viral hepatitis. No serial monitoring is required. LFT can be done safely after 2 to 3 weeks and after 2 to 3 months to see whether there is normalization of LFT. School, when the child feels so. Usually what we say, the epidemiologists say that the child should return after 10 days because that time the fecal-oral transmission, the child can transmit the virus to the water or to the is less after 10 days. So they can return, the epidemiologists say 10 days, but otherwise what we say that the child is fine, he's ready to go to school, he can go back even with yellow eyes. So the yellow eyes should not be the criteria to go back to school. So these are my suggested readings. I should recommend that this article by Moinak should be read by everyone who's interested in hepatology and hepatitis. It's a very beautifully drafted article. Can I take my next talk?